Hello, everyone. Welcome to yet another episode of the Para Podcast, where we explore the people, the practices, and the progress shaping the paramedic world. I'm your host, Tulani Thomas Sibanda, and as always, I'm with Malusin Tetwa and Mr. Elias. I nearly said Mr. Elias Tetwa, Mr. Elias Thomas.
That can be my middle name, my African name. Because these people keep saying I don't have a middle name.
And today we are diving deep into conversations that breaches the front line of paramedicine, healthcare strategy, and cutting-edge research. Joining us today is a remarkable guest, Mr. Justin Thomas, with over a decade of global experience in emergency medical care, disaster management, healthcare systems, and aviation healthcare operations. Justin is a seasoned leader, educator and innovator in the EMS space, and he's currently pursuing his PhD at the Oxford. I hope that I got that right. At the Oxford University. It's at the University of Oxford, where his research focuses on shared decision making within the ambulance context. But we'll chat more about that. In this episode, we'll unpack his journey from the streets of South Africa to the skies over the Middle East, explore how paramedics can better align care with the patient values, preferences, and discussing the future of EMS through a more, what can I say, inclusive, data-driven, and human-centered lenses. So whether you are an aspiring paramedic, healthcare strategist, or someone who's passionate about the evolution of emergency medical care, this is an episode that you don't want to miss. Justin, thank you for coming to the podcast. How are you?
I'm good, thank you. Thank you for having me. It's a pleasure to be on your podcast.
All right. Thanks, Justin. So we just gonna get into it. It's a pleasure to have you on the Para podcast. And before we get into some deep stuff on shared decision making, social prescribing, and all the academic brilliance, and I must say you've got you've got such a rich journey behind you. Let's start right at the beginning. Can you please tell us a bit about your upbringing? What what first sparked your interest into helping people or joining paramedicine?
Sure. So growing up, I never actually wanted to be a paramedic. I wanted to be a doctor. So I worked really hard to get into healthcare. But that I think stems from my parents and my grandparents, who did quite a lot of work within the community. My mom and dad, whilst I was growing up, ran a center for people that were both infected but also affected by HIV and AIDS right in the beginning when HIV was becoming a huge problem within South Africa. So I grew up with them in that space, and I also did volunteer work in the center with them, specifically in the hospice where we worked with some of the patients that were passing away in that space. After that, my mom left and she began to run a center for abused women and children and victims of gender-based violence. So I also got involved in that as well. What they would do is the forensic assessments for the victims before they would go to court. So the social workers would then do the interviews with the survivors as well as write all the forensic reports that would be used as evidence in the court to support the prosecution. And so I learned quite a lot from that space about things like child rights and women rights and all of that kind of thing. And then my grandmother also, she worked with street children and was very, very involved in sort of community development and that kind of stuff. So growing up, I was exposed to it quite a lot. I was very silly in my final matric year. I wrote 2 exams for every subject, and for no reason. I only studied for the first exam and I didn't open a book for the second one. And as a result of that, I didn't get the marks I needed to get into medicine. So-
You're testing the system, man. You wanted to see how far the brain can take you.
No, the system tested him.
Yeah, testing.
So I got into a Bachelor of Health Sciences in Biomedical Sciences at Wits first, and then from there, that same arrogance continued for no reason apparently. I also decided I didn't need to study at Wits, so I bummed out completely at Wits, and then was excluded from the university. And so in that December period, whilst we were trying to figure out what I was going to do, my dad said to me, well, why don't you become a paramedic? So I was like, okay. And then
Because that's where we throw trash, eh?
Yeah. I was gonna say this, but I didn't want to be the one. There is this other course, it takes everyone in anyone. Why not try that?
So
Wow.
we had friends that had family who was a paramedic, and that paramedic suggested that we do the BTEC route because they were phasing out the short courses. And I joined it with the intention of going back into medicine. So yeah, that was my sort of footing into it. But I've come to realize that I don't actually want to be a doctor, and I'm quite glad that I didn't become a doctor. So yeah, that's sort of my footpath into paramedicine.
It's an interesting journey that shaped your career path and towards helping people. And before we move on to your operational experience as an emergency care practitioner, how was it like for you to be in that hospice space or in that space where you were taking care of people that were subjected to gender-based violence, and also people that were infected and affected by HIV? Because I can imagine during those times that a lot of people were dying. There were not a lot of treatment options or plans for them, and the medicine was not advanced in that stage.
Well, it was really during the time where the South African government didn't want to introduce ARVs. So it was still during the whole Thabo Mbeki era where they were deciding that beetroot was the treatment phase. So that was
Manto Shabalala Msimang.
the biggest issue. There we go. So
Yeah.
people didn't really have options about treatment. But one of the things that really affected me in terms of that is when you sit and you talk with people. You know, when you're sitting in a hospice, you have nothing to do except sit in the bed and watch your life go by. And spending that time with patients, learning from them, hearing their stories, understanding where they come from, hearing the pain and the heartache of not having their family come to visit them, or spending time with the children whose families were wiped out by the AIDS pandemic, who were orphaned to it, where because of the stigma that was surrounding HIV, none of their family wanted to look after them. And so they became destitute. And when you begin to sort of understand those very real and very desperate situations that people can find themselves in, it has to move you, you know, towards wanting to help people, because it also shapes your understanding of what is vulnerability. What does it mean to have no options? Because when you are, for example, a 5-year-old girl who has lost her entire family to HIV, and she's got to look after her 3 siblings because she's the oldest, what does she do? Where does she get money from to get food? Where does she get money from to look after the kids? That specific case was a real actual patient or a real actual person that was in the center. And my parents and them they worked a lot with the community leaders who brought the kids to the center and then explained that this was what was going on. And when they went back, they then found out that, these 4 children were surviving because the surrounding neighbors were giving them food and helping them. But outside of that, there would have been nothing. And that sort of level of, I'm going to call it multidimensional poverty because that's exactly what it is. It gives you a different understanding about what is need and how desperate people can actually become. So for me, that was one of the things that I learned, that it was as bad as it was for me not having money. It was actually never that bad. You get a very, very deep frame of reference.
I've got a question, Tsunami.
Wow.
Sure.
Yeah, you can go ahead. Shoot.
Yeah. This is actually very interesting. I think this is another angle of a South African story that we have not really spoken much about. I think when I'm thinking about it, as you're talking, Justin, I'm thinking the period where Thabo Mbeki was the president is after Nelson Mandela. So it's around 1999, 2000 and stuff like that. And it seems like your family is continuously involved in the space of assisting people socially. I think during that period, there was high migration, people that were moving outside of immigration, people that were leaving the country because of the changes that were happening and stuff like that. Yet your family takes a position that says that we're going to assist the country while it's in this crisis. HIV was big, it was killing people. We saw it. And it's something that is still has impact now. People are still single parents and stuff like that. Sorry, single, they're child-headed household. I'm sure right now those people are adults and they're trying to make ends meet. It has impacted their lives. Particularly, I'm sure they couldn't afford universities and stuff like that. It just affected their social life altogether. My point is, what made your family to take that position? What made them to take that position as the people in that space and time of the political era in South Africa, that they wanted to be the assisting hand, assisting victims of sexual violence and assisting people that were affected by HIV/AIDS and the hospice and all that? I think that was very deep. But yeah, do you want to tell us how did your family take that position?
So my understanding of what happened at that time, because I was also quite young, I think I was only about 13 or 14 when that was happening. But my understanding of it was that it came from my grandmother, who was involved in the space through Rotary and Toastmasters and all of these organizations. And at the time, one of the industries in Vereniging was looking to set up a social development project to help people in the community, the surrounding community, as part of their sort of initiatives with government and all of these kind of things. And so my parents, we were living in Cape Town when that was happening. And my parents were not employed. So we were living in Cape Town for 2 years. They were unemployed. And we survived on food parcels from the church and things like that. My dad became a waiter so that he could earn money to support us whilst they saved up to move us back to Johannesburg. And then through that, my grandmother basically said to mom and dad, look, are you interested in working with me in this? And they were. So they moved back, and that was then where they came into it. My dad's side of the family, like I said, my grandparents have always been involved in it. So they left Ireland as missionaries from Ireland to come first to Rhodesia, and then from Rhodesia or Zimbabwe, modern day Zimbabwe. Then from there, they came to South Africa to do missionary work. They also had adopted a lot of people and children. So it was part of growing up. On my mom's side, my grandparents did the same thing. My grandfather would go and do things like hospital visits as part of church work and all of that. So I think that it was part of like our background basically and the way that they were raised. And so when that became an option for a job, they were quite happy to do that. Because it was a way to do what you love doing, but be able to earn money out of it. But also the money was not great. So it is what it is.
Yeah. I was gonna say, I was gonna say that not all the noble jobs, will reward you for the effort and time that you're sacrificing.
Yes.
Just that angle view, I had one question, and I know that this is something that we explore a lot, and it's usually not a person of your skin color that will have such issues. It's usually sort of like other, minority groups or majority groups in South Africa, for this instance. Like for instance, I was fortunate enough to go to uni and have my studies paid for. I'm not sure how you went about getting your studies paid, because I mean, obviously, looking at how you took university and what the outcome was, how was your experience? And, how did you manage to pay for your studies moving from one program to the next? If you can maybe just take us through that journey and how your experience was.
Sure. So we were quite fortunate that my mom and dad would get a bonus at the end of the year, and they used that bonus to pay for my school fees. Up until my final year, where we weren't able to, and then I have a rich uncle and aunt that my parents approached and asked would they pay for it, and then I paid them the money back after I graduated. So that was how that worked. But I mean, nowadays for me doing like my master's was quite expensive because I did it in the in Australia. And personally, I wasn't able to provide or pay the fees upfront. So I worked with the bursar's office literally every term to pay it off on a monthly basis. I would like clockwork get the email from them to say, you haven't paid your fees. I'm like, yes, I will pay it now. And then we would do that. And it's the same even now at Oxford, that I pay it off on a termly basis rather than as one lump sum through the year. So what I have found post-grad is when you work with the universities and you explain to them your situation, a lot of the time they are really willing to assist and help you. They just want to know that you are going to pay.
Like, you're not going to scam us. You are going to
Yeah,
pay.
yeah. And so I've been quite fortunate from that perspective, where I've been able to work with the finance departments at the universities, who have given me permission to pay it off in smaller installments rather than as a lump sum.
Look, kudos to your family, your grandmother and your grandfather for the work that they've done. It's commendable, helping those people, but also to you guys, your family, your parents as well, for doing that. I think it's commendable. And during those times were tough. You know, people were desperate, and also that emotional turmoil that it can take on you guys might not be easy, but somebody did it, and there were people that were helped. Now, coming to your operational experience as an ECP, look, we obviously come from the same university, one of the best university in. I
I'm
don't
sure
want
that's
to
a South African battle.
I don't want to start the battle, but
Malusi, what is your opinion on this? Because
We all know that number one university in South
University
Africa
of
is Cape Town. I'm not sure what are they talking about, but they can talk. It's okay. In Africa, not in South Africa for that matter. But it's okay. You can continue. Yeah.
Anyway, we come from the same University of Johannesburg, graduated as ECP. We would both work started at the same private ambulance service. And just to explain that the area that we worked in was Potchefstroom. It was busy time. And when I started there, I started working road ops. But on my off days, I would work on the Northwest Haley, which was started in April, I think, 2013. And then when I was about to leave, you came in,
Yes.
working as an operational ECP or emergency care practitioner on the road. And then you took it from to the skies as a flight paramedic.
Yes.
Now, what's were some of the most eye-opening experience from those early days in your career, basically transitioning from ground to air,
Mhm.
your perspective on emergency medical care, both clinically and personally?
Sure. So, I mean, as you've mentioned, we were working in the Northwest. The Northwest is essentially a rural part of South Africa. And Potchefstroom, it is a busy town, but it was a small town because it is a university town. So there were no sort of level 1 trauma facilities and things like that when you were there, but there was a lot of requirement for that. One of the interesting characteristics about Potchefstroom is the roadways. There were a lot of major highways that went through the town or nearby the town. And then secondly, there were a lot of old age homes that were present in that town as well. So you had this unique sort of characteristic where you were exposed to all of the old age diseases and everything that sort of came with that in terms of ICU and clinical care there. But you also got quite a lot of exposure to trauma because of the highways that happened through there. And so one of the major things that I learned from that experience is that transportation and the decision to transport is actually a decision for escalated care, and it's a clinical choice. It's an intervention. And the way that you make those decisions is important because it has a direct effect on the actual patient themselves. So for me, when I was working in that space, I was learning how to identify what are the sort of indications for using specific types of modes of transport. What is an indication for getting the HEMS? What is an indication for rather using a road ambulance to transport this? When would I not want to use a HEMS? Those kinds of things. That was the part for me that was the most important, because I think that it's something that we don't consider as paramedics. We take the option for transport for granted, and so we don't think of it as an intervention in and of itself. We don't always consider the impact that transport mode will have on the patient. And being in that space, being very far away from level 1 definitive care, you have to make those choices. When you're sitting with a patient where the nearest hospital is an hour and a half away, the nearest most appropriate hospital is an hour and a half away, that becomes an important decision. How am I getting this person from here to there in a way that is safe? In the South African context where you have road quality that is not the best, how does that impact transporting patients? And so that for me was probably the best skill that I have learned, because it has carried me quite a lot throughout my career. Especially when I moved into like the airport side of things, where that option is not always there. So yeah, that transport as an intervention, as a decision to escalate care. What are the factors that actually affect that choice, and how do we do that well? Those were the things that were very interesting and important for me, especially working from the HEMS side, because when you're on the HEMS, you have certain expectations about why you are being called, and you have kind of expectations about what you want to see when you get there. And that's also not something that, I mean, when we were students, we were never taught about things like dispatch criteria for a helicopter. When is it appropriate? When is it not appropriate? All of those kind of things. So that was something that I learned through working on the HEMS. What can I do on a HEMS? What can't I do? When is this suited for what type of patient? And I remember a very specific example where I was dispatched to do an IHT from the hospital to Johannesburg. When we got there, the case of the patient was an aortic aneurysm. And the background to that was that the size of the aneurysm had tripled overnight. And so I was like, okay, this is not good, obviously.
That's why you're here.
Yeah. So I sat and I thought to myself, this patient's dissecting aneurysm is clearly moving, it's clearly growing, there's clearly an active bleed. How does moving this patient via a road system that is a terrible road system because it's in terrible condition with potholes everywhere, how is that going to impact this person's health? Normally, you would not fly an aneurysm because they don't meet flight criteria. And the reason for that is because if the person's aneurysm pops in the helicopter, you can do nothing for them. So you can't do CPR. There's no space for that. You've got to land the helicopter, take them out, all sorts of other things. At least in the back of an ambulance, you can begin CPR. You can do other things to try and assist. But in this particular case, I felt that moving the patient via the road would actually be harmful to that patient. And in my view, it was sort of a contraindication because the aneurysm was so unstable that if we were to hit a pothole, there was a risk that it would pop. So I spoke with the flight MO. We spoke with the medical aid MO, discussed and shared my concerns with them. They agreed with me, and we were able to activate the helicopter, who then came out to pick up that patient and transport them without any issues. And I think that that's really what it is that I'm sort of saying, is when you are sitting and considering the decision to transport, it's important to look at these kinds of factors. What is the reason that you want to use this particular mode? A lot of time, people don't always realize that a fast HEMS call out is 45 minutes. It's that simple. You don't call for the HEMS and 10 minutes later, it's at the scene. So when you are sitting and you have to wait 30 to 45 minutes for the helicopter to come, how are you justifying that decision clinically when the hospital is only 25 minutes away? If you are the most senior clinician on that scene and you're wanting to escalate care because you need additional resources or additional skills, how are you doing it? How are you justifying that? Especially when you consider that most laws are written where there is a legal requirement for us to make sure that the patient gets to the most appropriate care as fast as possible, the nearest most appropriate facility. How do we make those choices? How are we sitting and actually making that decision about, I need a doctor to help me with this, but where is the doctor? Is the doctor on a PRV? Is the doctor on the helicopter? Is the doctor in the hospital? Which one is closer? If I'm looking for an ECP to come with a skill or an ALS with a skill, which one is closer? Does that make sense?
Yeah, it does. It does. I think it's a very interesting concept because it's just like, I think on one of our podcasts when we spoke about social prescribing, doing the small things for the patients, and sometimes we don't really consider it as sort of like a framework, like a process that needs to be in place and needs a lot of consideration. And I think you sort of like dissecting that whole process. And in all honesty, I was just thinking that I'm not gonna move that patient. I think that facility must try and see how they can stabilize you, because for me, you are very unstable. I'm sorry.
Yeah.
But yeah, thanks for sharing that experience. It's really informative, and I think for the guys out there, I think they should feel empowered to make these decisions and communicate and see what resources they have available to make decisions that are in the best interest of the patients.
I think that to your point about whether you're deciding to move because of stability, and the capability of the facility. I've had those cases as well where you've gotten out to a patient who, has been unstable. You're watching the VEs, the ventricular ectopies, come and go like it's gone out of fashion on the ECG. And the reality is that when you get into that space, you know that this person needs to move. But you realize that maybe actually the diagnosis of the physician is not correct. And that has happened to me, where the person was diagnosed with some complex renal failure problem. And then the nurse was sitting there emptying out the urine bag that had like 2 liters of urine in it. And I said to her, I asked her, I was like, when was the last time you emptied it? She's like, no, this is just for this morning. I'm like, okay, so it can't be kidney failure if we have a huge amount of urine coming out. That's not how kidney failure works. So what else is going on here, And then sitting and looking in, seeing that something like DKA, which actually was in that patient, we ended up diagnosing that patient with DKA. That's something that can be managed in that setting. Getting to the correct diagnosis, you feel comfortable then leaving there because you know that we can actually resolve this issue. But then there are some other situations where it might not actually be that clear cut. In that specific hospital with the AAA or with the dissecting aortic aneurysm, they didn't have a cardiothoracic surgeon there. They didn't have a vascular surgeon there. So there was no real option to stabilize the patient. And also, what do you do to try and stabilize that patient? How do you stabilize an actively dissecting aneurysm?
You call Justine.
And I make the decision to
that's what you do.
Sounds like a superhero.
Yeah.
sounds like an ST.
Justine. It'll make a good advert.
So I think that deciding what is the most appropriate care and where is the nearest most appropriate care. If the nearest most appropriate care is in that hospital because we've given them a correct diagnosis, then keep the patient there. But if it's not there because they need additional resources, let's try and stabilize and then move along. And I think that that's also the nice thing about interfacility transfers. You have that time to play. You have the time to sit with the patient, make sure that they're stable, make sure that they're comfortable on your equipment, that you can do that and then move them. There are some patients that it will take too long to stabilize them. So I have had situations where you work with the treating physician, you say to them, this is what we need to prepare them for flight. If I can ask you to do this, do it. Call us back in the morning if they're not fixed and we can help you transfer. But for this particular moment, if we move this patient, they will not even make it from the hospital to the helicopter or the aircraft. So it's not ethical to move them from where they are. But I think that it's very much determined on why are we moving this person.
Wow. So look, from my personal experience, having worked HEMS, especially in Northwest, even in Africa, in South Africa, not Africa, is that the decision to transfer critically ill patients from one hospital to another, especially if they are critical, it's always an ethical and moral dilemma for us as paramedics.
Yes.
And you always have to look at the patient safety versus the potential benefits. And but the main thing is the primary concern is the patient's well-being. Where you're moving a critical ill patient carries inherent risk. But you look, as you said, is that what are the potential benefits of transporting that patient? Where they're gonna go? They're gonna get specialized care to treat them? And you sort of take that risk. Unfortunately, some of those patients do not make it. And the thing is, it's something that has happened to me, whereby if you leave that patient, they're gonna die. if you take them, also the risk is there. So what do you do? And one other thing that you mentioned, and something that I don't think we speak about it, is that when transporting patients in aircrafts, in helicopters, it's like the space is very small.
Very small.
To resuscitate those patients, it's hard. But with the advances in treatment, where you've got machine CPR, there's things that you can attach or you can prepare for patients that should they go into cardiac arrest. But thanks for sharing that experience, Justin. And moving right along, so I'm just going to move on to the next set of questions that from clinician to chief, from clinician to chief, you moved up ranks from duty supervisor to chief EMS at a major international airport. What prompted the shift from a hands-on patient care to leading an entire services? And just in the podcast, one of the episodes that we've done, and I'm glad we have a white person here because I've been,
Yeah.
I've been told that the movement of us to for greener pastures in other countries is from a black man's perspective. From a white man's perspective, what were the push factors for you to move for that move? And what prompted as I said, what prompted the shift from patient care leading to entire service?
Okay, cool. So I think, there's two parts to that question. So the first part about why am I an expat and why have I remained an expat for the time that I've left? I think that it's the same reason that everybody leaves. We love our family and we want to give them a good life. And if that opportunity is not available in the town or the city or the country that you're living in, you move. For me, my first job was not in my hometown. I had to move towns to go to work in Potchefstroom to get that. After that, my next job was also not in my hometown. That was in Heidelberg. So I had to leave and go and work there. But you go where your skills are needed and where you are able to make ends meet. In terms of that position at the airport, one day I kind of just got a message from LinkedIn saying, I have a job for you. If you're interested, I've sent you an email.
It works, guys. LinkedIn works. Keep those profiles updated.
I'm telling you. And it was during that time period where there was a lot of scams about like these jobs and you have to pay them and whatever, and then you never get the job. So I was very suspicious. And I went back and I didn't reply. I looked to see, well, what is this company? Are they advertising? All of that. And then I found the company, and the company was registered as a cleaning company. And in my mind, I'm like, why is a cleaning company paramedics? So it was like,
need to be a cleaning manager, maybe.
This is not great. So I then went back onto my LinkedIn and like randomly I found that actually I had a contact who was working in the service that was offering the position. So I chatted with him and I said, look, this is what's happened. I've received this job offer. Is it legitimate? Like, what's going on? And he was like, no, yes, this is how it happens. You don't have to worry about it. And that was basically when I accepted the position to move to Saudi. When I got to Saudi, I didn't really know what to expect. I came into it just with a very open mind. And what he explained to me is that it's like working for the public sector in South Africa, but you just get paid more. And so I was like, well, I can understand that. I'm currently doing that. So I'm fine. Like, we can do that. Let's go for it. So we moved.
What were the similarities? I'm interested between the public sector and that.
It was basically lack of resources. So what he said to me was that there wasn't that much resources, and also the clinical leadership or the leadership was not that fantastic. So I was like, okay, cool. I can understand that. I work in a resource limited setting. It's not an issue for me. Let's see what we can do. But when I then got into the airport, and this is leading to the second half of that question, what I realized is that the reason why there was a lack of resources and the reason why there wasn't a lot of, I'm not going to say good leadership, I'm just going to say inexperience in managing healthcare settings was simply because, number one, they didn't have standard operating procedures for those kinds of things. And number two, the people who were managing the healthcare service were not clinicians. So you can't expect a non-clinician to know how to manage a clinical space. And so in that area, there wasn't a chief paramedic. He had actually left 2 months before I arrived. And so it was myself and 2 other EMS duty supervisors who needed to come together as a team to try and fix things. What I realized when I was there quite quickly is that the airport is a very regulated environment and aviation is extremely regulated. They have rules for literally everything, even down to like the color paint that you use on the runway, the like width of it, the font that you use for the text, everything except ambulance services. There is, in a 300-page document, which was the regulation for it, they had half a page. And the summary of that was basically, if you want to have an ambulance service, you can, but it's not required. And if you do have it, make sure that it sort of relates to the amount of services around the ambulance, around the airport. So that was the guidance. It was not very prescriptive. And so we were kind of left to our own devices in terms of that. And so at that time, I was really like, I need to do something because we can't have gloves running out every single month. We can't have basics like glucose test strips running out every month. And so I then registered for the masters that I did. I did a dual masters one in international public health and then a second one in health management that I studied at the same time. And through that, one of the courses that I did was on clinical governance and risk management. And they basically, in that course, I learned about a concept called systems thinking. And that has sort of like revolutionized my way and my approach to managing healthcare services just generally, but also just my way of understanding cause and effect. And as part of that, we had to do a work improvement project to solve some issue in the workplace. And I thought, you know what, let's find out why we are running out of gloves every single month. And so what I did was very simple. At the time, you didn't have to do anything to check out the stock. You could literally just write it on a piece of paper, leave it in the front desk, take the key, get whatever you needed, and then that was it. So I was like, well, what happens if we force them to identify themselves? So we put a little sheet of paper, and if you were going to check out the gloves, you had to write your name on it. You had to write what was the size gloves you took, the day that you took it, and for which ambulance you were going to use it for. And what we found, we ran the project for about a month. And what we found is that during the project period, our consumption of gloves dropped by half in comparison to the 8 months before that. And so I was like, okay, well, something's changed. What is it? And so we began.
Why is that? Yeah.
Yeah. So we began to interview the staff members to find out what was different. And through that, we began to realize that actually the reason why we were consuming so much stock had nothing to do with our staff. It was related to all these other people who would come and ask for stock. And the staff didn't feel that they were able to say no. So they just gave it to them and then came and got more. And so through understanding that, I was then able to work with the fire chief at the moment and say, look, this is the issue. We're burning through stock because non-clinicians and non-EMS staff members are essentially taking it off of the ambulance. Can you give me a letter that we can put on the ambulance to prevent that from happening? He was very happy to do that. We did that. put it on there. The staff were then able to show this letter signed by the chief and the chief of fire. We can't give it to you. Nobody questioned it. But then we also began to tailor and change the way that we did stock even more. So we began to sort of issue stock based on the consumption that people were using on calls. And so that basically cut down the stock consumption to about 15% of what it was. And to give you an idea of that, I mean, in the first year that I got there, our stock budget was 2 million riyal. By the time I left in 2024, I had dropped that to 150,000. So
was that a Doge system?
Yeah. Someone was applying something.
Typical South
much worse.
Africans, eh?
so it was one of the reason that we transitioned was because we needed to. We couldn't, I couldn't continue operating a service where we were that inefficient and also where we didn't have the stuff that was there. But then I sort of realized that I actually have quite a knack for this and I enjoyed doing it. And so the other two duty supervisors didn't like the admin side of it and they were just happy to let me do it. So I did. And then I became the de facto sort of chief paramedic. Until I finished my master's and then was promoted directly into that position.
And look, I must be honest, and the stock I never paid attention to. I just took the stuff that I needed to use, and that's it. Even till today. But I think if you at a place whereby stuff is running out, there's no control, then it becomes a huge importance to regulate it. Because then, what if people are misusing it? But it sounded like when you joined there, a lot of the things were not being done. There was a lot of introduction of stuff, and I can imagine maybe that was frustrating for you. I don't know, but it had to be done to put that system to be in that place. And you spoke briefly about the 2 masters that you did. Was it more on? Was it pure research, or did it also have coursework? Do you mind telling us about that?
Coursework. So I only did a master's via coursework. I elected not to do the research component of it. And the reason for that was that I wanted, at the time, there wasn't a master's that would increase my scope of practice. But I didn't want to do a master's that was just going for the sake of doing a master's. I wanted to do one that was going to increase my knowledge base and give me more skills as well as longevity in the field. So we know that as paramedics, you can't work really on an ambulance when you're 65. So even for most people after the age of 40, it becomes a little bit difficult, sometimes even earlier than that. So I wanted to have options when I was tired of being in clinical care. And why are you laughing, Elias?
I know what
He's
he's
gonna
going
talk
to say. I know someone.
Are you touching someone's ears, Elias?
Let's proceed.
So I wanted to have options for when I was no longer able to work on the vehicle. And health management was something that I really enjoyed doing. I learned a tremendous amount through that degree. And we can get into exactly how that has shaped me as a leader, as a clinician, as a manager within a service as well. And then the international public health was something that I was interested in, even as a paramedic student, where one of the lecturers that we had in that emergency services administration subject, he was talking to us about public policy and said that to his knowledge, there were no paramedics who had specialized in public policy or in public health or anything like that. And so I thought, okay, well, that's a gap for me in the market. Maybe I can look into that and see if it's something that I'm interested in. And so I specialized my international public health qualification to give me the knowledge to run the airport system, to understand how international travel and all of these kind of things work, but then also to understand how disease is imported and exported between different places. So if you think about the way an airport works, as a patient or as a person, we carry disease with us. When we get on that flight, we move to another place, and essentially we have exported that disease to a new location. And that's why when you look at something like COVID, that's exactly what happened. COVID was exported to the rest of the world through China or from China. And understanding what are the factors that affected that was something that was very interesting to me. So I looked at epidemiology, and how do we actually measure disease within populations? How do we measure the factors that affect what populations get what diseases and all of these kind of things? And then I also look very carefully on infectious disease and communicable disease. So how do we control for that? All of that kind of stuff. In the IPH, and then in my health management course, that was really all about how do we manage healthcare services. What I loved the most about that, and probably the biggest takeaway that I could have had from that, is this concept that healthcare workers are characteristically different to any other kind of employee. And as a result of that, the way that you manage the healthcare workforce is completely different to how you would manage any other workforce. I'm sure that you want me to get into that.
So I think we're going to run out of time. So we'll probably talk more in discussion about on the next segment.
Sure.
The one thing that I wanted to say, do you want to ask something, Elias?
Yeah, I just had a question. Of course, Justin, I think one thing that is a bit of a dilemma for most paramedics is sort of like deciding what to study after you have achieved your bachelor's. I think that is one of the things that most people struggle with. Or some people just go with their career just being paramedics, but they are not really sure as to, firstly, where to study and what to study. And how do you determine sort of like where to go, especially for, and obviously I'm sure you have explored a few things, having studied your qualifications at the same time, studying in different countries. What would your advice be? Because I know a lot of people that try studying through the UK, it's very expensive for an international student.
Yeah.
Or going to Australia, it's very expensive. So what would your advice be for that clinician that's been on the road for 10 years, still holds a bachelor's degree, most possibly has a decent job, but they're unable to go for coursework or attend classes and so forth because of flights or whatever the case might be? What would your advice be in that instance?
I think that, my first advice is that you need to know what it is that you want. So you need to know where you want to be before you can know how to get there. And I don't treat education as something that happens by chance or happenstance. For me, it's if you have very specific goals and you can see how this is going to help you achieve those career goals, then do that. But if you don't have career goals, what's the point of doing the education? So understanding what are your goals, what are your career goals, is quite important to knowing what you need to then study. And a lot of the time for new graduates, I don't think that it's advisable to think of that immediately. I think that it is really good to spend 1 to 2 years working in the system, learning the system, seeing what you care about in that system. And then based on that, make a decision about where can I see myself in the next 5 to 10 years and begin to position yourself there. If you are in a situation where you are 10 years into your career and you now have to make a change or you begin to think about these things, a lot of the time that kind of a person would have other commitments. So you will find that maybe they've got to like pay for their house and all of these kind of things. the decision to study further, the adult learner does that on purpose. So it's not something that I'm just going to do today because I woke up this morning and decided. There must be a specific goal that's associated with it and what you want to achieve by doing that. And based on that, you then make your decision about where you want to go. But I also think that, I mean, like my 2 masters, I did completely online and through distance. I have 2 degrees from Australia and I've never set foot in Australia. So there is the option of doing this. A lot of the time, I think that universities need to kind of step up and make that available to us. They should be putting these online options that help people work as well as study, especially for things like a master's degree or a PhD. I can't really see what is the need for us being there in person to do it. Unless there's some practical aspect that you have to do. But for the most part of it, it's not. So as an adult learner, the characteristic of an adult learner is to hold on to or to take the initiative and take their training seriously and do topic-specific training that is relevant to their work and relevant to their goals. If it's not aligned with that, then most adult learners would not be interested in doing that. So I think creating programs that are flexible, that allow for people to choose coursework that aligns with their goals is one part of it. But also as a person, as a student, know what it is that you want. Know what you feel you need to know. Where are you lacking in knowledge? Why do you need to take this degree to get to point X? That's part of the reason why I don't feel I need to go to study medicine, because my career goals don't need that knowledge. I can get there just with a PhD.
Yeah, I wanted to add there. Thanks, Justin. I wanted to add there before Tulani shuts us down.
Wow, you're making me sound like a horrible person.
You're always talking about time. Anyway, I wanted to say I would like to invite our viewers to also watch the episode where we talk about the career development in EMS. We do talk about that. I think it's important that possibly in the first 3 years of your career, and also considering where you were strong at school, consider that first 3-year period of your career, trying to understand yourself. Where do you want to fit? Do you want to be in academia, in management, or you want to be in research, or you want to be an academic, or you want to teach vocational teaching? So it's very important that you understand that. And I also like what Justin is saying, that there should be means of studying online without really having any contact sessions. I did do my master's online. I was meeting with my supervisors online and through email and stuff like that. Also, similarly, even the PhD that I'm doing at the moment, I'm also doing it. I'm not exactly online, but I'm meeting with my supervisors online and everything is done online. I'm also aware, I'm not sure how many contact sessions do they need. University of Pretoria does have, I think, public health that they offer. A lot of people from GPG have studied there. I think they offer some course there. I know that there's a research component that they do. I'm not sure how much. I mean, how much of that is management or public policy or research, but I'm aware that there's something like that there. So there is a whole lot of other options that are there that you can use. I know that also in Cape Town, there is that master's degree that they offer. I know they have a lot of contact sessions there to a lot of people that are employed do struggle with those things. So there are a couple of options that are out there. But I do think that there needs to be another clinical course that is online that can be learned by advanced clinicians that want to study further. I think it's something that should be considered. And also, once there could be not only limited to South Africans that have studied in South Africa, they will also get other international students that could study in South Africa if they want to do intensive care paramedicine in a context of South Africa. And because I do think that there's a lot of value that they can learn from that, not only study in the country where you studied. That's another discussion, though. Let me stop there.
Can I just quickly build on what you're saying, Malusi? I think that part
Yeah.
of that as well is knowing where is the future of healthcare going. So when you're sitting and you're looking at how systems are progressing, understanding how am I positioning myself so that I still have work in 20 to 30 years is important. And there are a lot of options available to that. There's a lot of things that you can do in digital health at the moment where you can learn about health tech. You can become an entrepreneur when it comes to those kind of things. There are so many different options that are available that are in peripheral industries, not necessarily clinical work in paramedicine. It's one of the beautiful things about being a paramedic is that our skill set allows for us to adapt to any situation and any setting. And if we're beginning to think more broadly about those things, you can see that your career options are quite large when it comes to that. You don't have to follow the prescribed pathway. You can look to see what are you interested in and how do I create that pathway for myself?
Sorry, I was just gonna ask, do you think AI will take our job or no?
I don't think, I don't think that AI will take our job, but I do think that AI will come into play in a lot of the way that we do things. So if you sit and you look at things like data management through EPRF systems, that's big data sets that you're not always able to actually analyze by yourself. So if you want to understand, for example, how can I use a massive data set for my organization to help me improve the functioning of my organization, large language models can definitely help you with that. If you want to know how do I create a dynamic emergent or staff rostering system where we begin to look and see how this staff member, how busy was their shift in the last month as compared to this staff member? And how can we better put them on an ambulance that will help balance the fatigue across that section? AI can be a very good tool for that. How do we do things like managing stock consumption using AI? And I think that learning about those kinds of things, how do we use this as a tool that can support us in our practice? I think that that's where AI has a lot of benefit. I'm not suggesting that it will take over the job of becoming a paramedic, but I do think that there is definitely ways that incorporating AI into our practice, into management, into decision making, into identifying novel things. So maybe, for example, you're sitting with a patient, you have no idea what's going on with them, but you're in a rural clinic somewhere in Congo and you don't have options to transport. You've got to treat the person in front of you. AI can be a tool for that. You know,
Yeah.
that's all that I'm saying in
So
terms of that job.
all right, sorry to cut you off. I think there's a lot of meaningful discussions in this conversation that we've had. And one of the things that you mentioned, I like the stuff that you mentioned about AI and that we have to use it. That sounds to me that we have to use it responsibly
Definitely.
within our profession, and it will help us to engage the work that we do. But also, you also mentioned about we have to be. I think when you hit the nail or you hit the crucial point when you spoke about intentionality in paramedic, is that it's often it's often and overlooked by aspiring and experienced paramedics. So intentionality in the professional development is important. The field of paramedics, as you said, is incredibly diverse. and simply being a paramedic can mean many different things, as you've alluded. So to truly shape your career and maximize your impact, you absolutely have to be intentional about what you want to study and how to develop those skills. I mean, one of the things that we do on the podcast is that we try and educate that, as Malusi has added, is that if people want to see the paramedic development, career, profession, how to develop, go watch one of the episodes. You also introduce something that people didn't know about, probably never thought about public health, which forms a huge part of us as emergency medical services. But yeah, I think we've run out of time. I just want to end this episode here.
Sure.
And thank you everyone for watching the Para Podcast. And cheers.
Yeah. Don't forget to like and subscribe and share the podcast with everyone else that enjoys content like this. Thank you very much, Justin, for coming through. And that's a wrap.